Ms. Cartwright.
Good morning, my lady. The gentleman by the witness box is Professor Spector. Could I ask, please, for him to be sworn?
Solemnly,
Sincerely and truly declare and affirm
sincerely and truly declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth, and nothing but.
Good morning. Could you please give the inquiry your full name?
Timothy Spector.
Professor Spector, you've provided a witness statement to Module 7 dated the 24th of March of 2025. Could I ask, please, for the page 12 to be displayed, where we see your signature? And can I ask you, please, to confirm that the contents of that statement are true to the best of your knowledge and belief?
They are.
Thank you. Professor Spector, the principal area of your evidence you're going to assist us with today is the work of the Zoe app, the symptom app during the pandemic. But before dealing with that, can we first of all identify you, your background, qualifications and experience, please? It's right, isn't it, that you are a Professor of Genetic Epidemiology from King's College London?
That's correct.
You are Director of Twins UK, and perhaps do you want to just explain to her ladyship the significance of Twins UK and how that caused the adaptation for the symptom app, please?
Twins UK is a group of a cohort of 16,000 twins that I set up in 1993 that we've been following throughout the whole of the UK. And these are identical and non-identical twins that we use to investigate the causes of all kinds of common chronic conditions by comparing discordant and concordant twins, nature v nurture. And so we'd had a lot of experience at asking hundreds of questions on hundreds of diseases over the years, and so became quite expert in a very broad way of looking at health and the causes of disease.
Thank you. It's right, isn't it, that you're a consultant rheumatologist as well as your expertise as an epidemiologist?
That's right. So, yeah, for at least my first part of my career, 20 years, was in rheumatology, which, again, is a branch of medicine that looks at clusters of symptoms, often without definite tests and conditions, and is to be a good diagnostician, you have to pick clusters. So that ended up being useful in this line of work.
Thank you. And again, by way of relevance to the COVID symptom study app, it's right, isn't it, that you are co-founder of the science and nutrition company Zoe?
That's correct, which, we founded in 2017.
Thank you. And as now we'll be moving to, you were the lead researcher behind the COVID symptoms study app.
Yes.
Thank you. And can I ask you then to explain to her ladyship how it was that you moved to develop the COVID symptoms study app, please?
It all happened as my department was being told by the university that we had to all go home and stop our clinical studies. And cycling home that day, I said, I can't just sit and do nothing at home. Let's think of a way that we could use our twins to act like canaries in a coal mine, if you like, so that we would get something to them. They're all over the country. It would be a perfect way to see what's going on using the common symptoms, and thought that the app was the best way to do it. I got on the phone, discussed this with the CEO of Zoe, Jonathan Wolfe. He thought it was a brilliant idea, spoke to the company, and then so they agreed. And at the same time, I spoke to my colleague, Claire Steeves, who was a geriatrician who'd been working pretty much on the front line. And she knew about the symptoms, she knew about testing, and so having those two together, the company that was willing to transform their team from doing nutrition into pivoting to do something for the COVID effort, plus having the clinicians on board from St Thomas's Hospital, was just the perfect combination of a team that could make this happen. And we initially wanted to roll it out in just the twins to see how that got on. But at that time, by the time we'd got it ready, it was clear that there was going to be a full lockdown, and so we released it to everybody. We said there's no need to do it more.
Thank you. If I could just pause you there, Professor Spector, because we'll deal with what you were able to achieve over a very short time period in a moment. But could I ask, please, for paragraph 4 of your witness statement, which is INQ 575990 at page 2, to be displayed, please. Professor Spector will appear on the screen. And can we expand paragraph 4, please? You've just referenced Claire Steeves, and I just want to pick up with you, please. We can see the particular thing that Dr. Claire Steeves was raising with you on the 18th of March, that I think was what you've described as pivotal as to what was needed. And in particular that, I summarise it, but the content is there, that essentially in a care home, someone had tested positive for SARS-CoV-2, and she had wanted to get all of the staff and patients tested, but couldn't because of the restricted centralised rules on testing, and that nurses in the home had reported non-triggering symptoms like loss of sense of smell and a hoarse voice.
Yes, that's correct.
And can I ask you, because I know with your evidence, you've provided a huge amount of literature in your literature review about the good work done by the Zoe app, referencing Dr. Steeves and her identifying early on the desire to test when there were no symptoms. One of the pieces of literature you provided, I think, deals with what you identified from your work that we'll come on to, that set out the importance of testing for healthcare workers. And can I ask you just to give that evidence, so before we get into what you achieved with the COVID app, using what Dr. Claire Steeves had flagged on the 18th of March, please?
Yes, so she was worried that frontline workers weren't being given the support they should have been. There was only very limited restrictions on who could get testing, and no one was really asking them about their symptoms. And many of them didn't have full PPE because it was quite restricted. So that was one of the big drivers behind us trying to launch this app and give more freedom for healthcare workers to find out whether they were infected or not, and also protect staff. And this culminated in a paper very early on that we managed to look in the first month in the US and the UK at healthcare workers and their risk of getting COVID using this symptom app, comparing it to the likelihood of getting a test. And so this showed us that they were getting something like between 11 and 60 times the risk of developing COVID compared to the general population. And that increased when they had poor PPE, it increased if they were ethnic minorities, and it was 3 to 4 times worse in the UK than in the US. So clearly there was something wrong with our systems in place. The risks were much greater for the healthcare staff, and we wanted to give them every tool possible to protect themselves and their patients, and that wasn't the official case. So they weren't being helped by the lack of testing.
Thank you. Professor Spector, you've just referenced the US. It's right, isn't it, that the app you went on to develop was not only available in the United Kingdom, but also was of use in the United States as well? That's
correct. A week after we launched, we did the same in the US.
Well, can we then capture the work that you did to launch the app, please? Your statement details how you managed to persuade your investors to take a risk and stop the company working on nutrition to pivot to developing the symptom app.
Yes, everyone wanted to help the general cause. The investors were there. They wanted to obviously make money. They'd put money into the company, but they saw this was a more important goal, and it was universal, their support. They said, yes, go ahead, do what it takes to get this app out there for free to as many million people as you can do in as many countries as possible, and we'll support you for as long as we can. And they did that. But we all expected that this would be relatively short term and that if it was successful, the government or some other agency would take it over.
Thank you. And perhaps if I cut through the timeline, it's right, isn't it, that by the 21st of March, you had essentially produced a version of the app on the Apple Store. So 3 days after the thought process as you cycled home from hospital.
Yes, we had a very crude version in 3 days and a more refined one in 5 days.
Thank you.
So it was sort of usable in 5 days.
And I think your statement also talks about how you utilised your communication strategy for the Zoe app to publicise the COVID symptom study app to get then the engagement with people downloading and using the symptom study app.
That's correct. So this was a very new way of us communicating, but through Twitter and Facebook, we got other people, influencers, to help us. Phoned up everyone I knew who was more well known than I was, which was most people, and people like, celebrities like Stephen Fry, etc., Emma Thompson, other people wanted to help, and then they spread the word, and it took off massively. So in 24 hours we had about 1 million downloads, and eventually got to 4 million, as people really wanted to help and do something.
Yeah, thank you. And I think you've already crystallised the 1 million downloads in 24 hours, and I think that you were at 2 million downloads by the end of the first week. Is that correct?
Yes.
Thank you. Can I then ask to be displayed on the screen, please, paragraph 8 of your witness statement, which is at page 3, please. And if paragraph 8 could be expanded, thank you. You say this, that the initial version was specifically designed to be very simple, to take as little time for people while collecting the essential data. The first days it contained only 9 symptoms, including the 3 official ones designated by the government: fever, cough and shortness of breath, and others like diarrhoea, chest pain, confusion, skipping meals and sore throat. But by the 24th of March 2020, we added other symptoms in, as we learned from case reports and colleagues in places like Italy that symptoms were much more widespread than had been reported by the Chinese authority. We eventually asked our over 20 we eventually added, I think that should be over 20 symptoms, and we could drop those found not to be relevant. One of the first symptoms we added was loss of smell or taste, anosmia, on the 24th of March 2020. And you then tell us that by the 27th of March, Dr. Frieden, who is a postdoctoral researcher, biostatistician, epidemiologist from King's College London, developed a model which identified that this symptom was strongly associated with testing positive for COVID-19, and we made steps to enable this to be written up quickly. And if we look as the paragraph continues over the page, I think significantly the early utilisation of the app had also identified that, again, with the assistance of your NHS and King's colleagues, including Dr. Steeves and her team, you found that in the elderly aged over 75, acute confusion could be the only presenting symptom, which eventually changed guidelines for testing in frail older people. And we also had a novel feature that allowed people to report symptoms daily on behalf of, as a proxy for elderly relatives, friends or children. So I've just summarised your statement, but perhaps if you want to convey the significance of the identification of loss of smell and taste to an identification of an indicator of being infectious for COVID, please.
Yeah, I think it was a great example of staying flexible and realising that you didn't have all the answers at the beginning of an outbreak, and you had to actually collect information and then change things as they went on. And just because you'd printed 1 million posters doesn't mean that that was the truth. And I think what we did is very early started asking questions so that we changed our mind on what we were looking for and what the best symptoms were to actually precisely identify someone who had an infection. And yes, in the end there were 20 symptoms we were asking. It turned out through subsequent analysis that we did very quickly that there were 16% of the population, this is based on millions of readings, 16% of the population only had loss of smell or taste, and they didn't have the other classical symptoms of fever or cough or shortness of breath. So that 16% would have been completely missed. Also, that symptom lasted much longer, so you might have had fever just for a few hours and it would have been not noticed or picked up, whereas the other one was much better. And when we compared all our data in one of these other papers with US data and from all around the world, it turned out that if you had that particular symptom, you had 11 times the risk of having a positive COVID test compared to the classic symptoms of only about 3 to 4-fold.
Thank you.
So it was just a real game changer in terms of finding something new that was far better than any sort of novel blood test.
Thank you. Now, can I ask you then, the paragraph I just read referenced the ability for proxies to be used on the app. And can you assist as to what the significance or the benefit was it permitting essentially proxy entering of symptoms to inform usability of the app, please?
When we first launched the app, there were a lot of criticism saying that no one above 60 would be able to use it, which I think people would find quite hard to believe nowadays. But that exactly. I'm also over 60, but this was, the press was saying, well, and government saying there's no point in launching an app because only young people will be able to use it. This was the thinking back in 2020, interestingly. So we first showed that, well, we had many people in their 80s using the app, but we did know that for some people with poor eyesight or other problems or very sick, they couldn't do that. People in care homes, for example. So we developed a proxy system, which I don't think anyone else has ever, I've not seen it before, that allowed someone on behalf of friends or family to report for them every day, and also their children. So people would be reporting for their children and maybe their elderly relative in a care home that they were looking after. And this was a really innovative, useful way of reporting, so we were able to capture a much broader section of the community. And it would have been, if we'd been able to do that more widely, and we'd had more support, we could have got that into lower socioeconomic groups as well.
Thank you. I'm going to come on to deal with the what-ifs in a moment, but I'm also going to come on to deal with the efforts you made then, having identified this significant finding, as to communicating that to the government to inform a change in the policy or identification of symptoms. But before doing that, can I ask you, we know that it was on the 18th of May of 2020 that the government added anosmia as an officially recognised symptom. But can I ask you, do you believe that the delay until the 18th of May could have weakened public trust, as people who experienced anosmia were told they did not meet the criteria for testing or isolation, despite the emerging media and international reports?
Yes, I think it was a major... Obviously, during the pandemic, there were many episodes that caused a loss of trust, but I think this was one of the major ones. People could see for themselves. All the GPs I spoke to said, this is ridiculous. I'm seeing all these patients with loss of smell and taste, and yet the government isn't changing its guidelines and not allowing us to test. And so generally, we were picking up on this feeling of lack of trust, and that grew, and that people then followed our podcasts rather than listening to government ones who consistently denied there was any effect when other countries several weeks ahead had actually changed their policies. So it seemed to be a stubborn response of the government that basically failed to look at UK data because it came from a predominantly symptom app rather than their own testing.
Can I also, building on that question, please, ask, do you believe that the delay in updating the symptom list contributed to preventable transmission, particularly among individuals with mild symptoms who believe they were not infectious?
Undoubtedly it did, yes. Many people had mild loss of taste. I mean, I myself did. Didn't realise what it was at the time. And I think there were probably hundreds of thousands of people in that situation. Some of them had other symptoms, but some didn't. So definitely caused unnecessary excess cases, which led to excess long COVID cases, which led to some hospitalizations, and people infecting their own relatives, which ended up being tragic when other countries had acted and the data was there.
Thank you. I'm going to crystallise with the communication from the Zoe app about this view about the symptoms, and then build on what efforts you made. Could we please have displayed 562712, please? That's INQ 562712. And Professor Spector, this is obviously taken from the COVID-19 symptom tracker. If we could move on a page, please. It gives us some idea around the messaging that went with the app. If we could move forward 2 more pages, please. Thank you. Thank you. Just pausing there. If we could highlight, please, the research update from the 1st of April 2020. So essentially, Professor Spector, you were confident to put on the website for the tracker that the analysis did exactly what you've told us about, suggests losing your sense of taste and smell may be the best way to tell whether you have COVID-19. Our researchers share their latest update direct from King's College London. And it may seem obvious, but why was it important for you to make your view clear about that on the 1st of April?
Well, as an epidemiologist, we're used to seeing multiple results of studies, but when you see something that's so clear-cut as this, that gave 11 or 12-fold increased risk of having a positive COVID-19 test, it leapt out at you that this is something the public should know immediately. There was no doubt that this was a spurious result. This was absolutely something that people should know instantly. They shouldn't be waiting for the slow academic route of journals, etc., even though it was super fast at the time. And that's why we wanted to warn the people that have been helping us with the app, collecting the data. And this was why the app was such a success, because it was a two-way process, that people shared their data with us, they trusted us with it, but they also trusted us to tell them when they could take action based on that information. So it was really part of our whole ethos in doing this, that we didn't wait for official approval, we didn't wait for the Lancet to fully publish the paper. We told people through every mechanism we could, through the app, through YouTube, whatever, what was going on, similarly to whether the area they lived in was dangerous or not. But this was a classic case, and hopefully the people using the app took action. Those people were possibly spared from infecting others.
Thank you. Now, you detailed within your witness statement that you were making weekly requests to the government to change the limited definition of infection and to make the loss of sense of taste or smell official policy. But can you, in your own words, to her ladyship, detail the attempts you made to work with the government in respect of the app, but also to change the symptoms, please?
Well, it started really with the symptoms. On a weekly basis, we were telling them what was going on. So as soon as we had the data, we'd say, this is what it's showing. You really need to change the guidance. At the moment, you can't get a test. You can't stay off work. You can't, use that as an excuse because it's not official. Please change these conditions. And I was emailing Chris Whitty and Patrick Vallance at the time. They said it's not our domain. We'll pass this on to the Deputy CMO, Jonathan Van Tam. And I emailed him a few times, didn't get any reply, and nothing happened. There was a press briefing several times because of our continued messaging. Some of the press were asking the government to do something about it, and each time they said, well, as far as I found out, there was insufficient data to change those criteria, although we'd shown them the data that was subsequently published in the Lancet. And generally, yeah, we wanted the government to get more engaged with the app. It wasn't our idea to run it as an independent organisation forever. We just thought, this is such a great idea. We've shown it works. Please take it on and use it and give it to everybody. But there was just no interest in that at all. And we were actually lucky to survive because, there were attempts to shut us down.
Thank you. And on that...
Sorry, what do you mean by attempt to shut us down? Lack of support arguably could be an attempt, but how else did they try to shut you down?
They contacted the dean of my university.
They?
As I understand it, was
Is this all
the
hearsay,
NHS.
or do we have any evidence?
Well, a lot of this was done through phone calls, so I don't have hard evidence or letters. So the principal of my university would phone me up and say, listen, the people are unhappy about this app because it's interfering with the government app. This is mainly from NHS X. I've told them that, I think it's good, but they're insistent. I also had pressure from the funding bodies like the Wellcome Trust to that I shouldn't be doing this. I shouldn't be using their name on my app because this was against government policy. So there was quite a lot of pressure that if I hadn't had the support of a private company, it would have folded very quickly. So that's what I mean. There was a lot of behind-the-scenes pressure that wasn't public in those first few weeks, particularly. The main reason being stated was that it would, if we distract everyone from the forthcoming NHS app, which was going to solve all our problems.
Thank you.
They had different functions.
Yes, but they said it was a contact and tracing app, not a symptom app, but they thought it was close enough that the public would get confused and they wouldn't download the NHS app. The reason I managed I came to a compromise, and there's an email about this, is that I agreed that in the event of the NHS app being launched, I would support it and tell everyone else to download it and use it. That was the basis of which a sort of détente was reached.
The government app, you say, is contact and trace. Were you aware of what other steps government were taking to collect symptoms, up-to-date data on symptoms, as you were doing, to the Zoe app?
I was not aware of any that they were doing. Their surveys seemed to be purely based on hospital records or blood collections. And they had very limited, they were only collecting the classical symptoms.
Yeah.
And even on their initial survey, so they had their official survey, they started just by asking the initial just 3 symptoms. Only later did they start adding more.
Sorry to interrupt.
No, not at all, my lady. Can we please display page 8 of your statement, please? It's paragraph 16, but it starts the page before, so it's page 8 I'd like to be displayed. And picking up on the theme that Her Ladyship has explored with you, that's INQ 575,990, please, page 8. Thank you. you've detailed in your statement the initial response of the UK government, NHSX, was not supportive. It was to initially try and see if they could stop us doing the app because they were worried it would interfere with the COVID-19 app developed by NHSX, which was in the trial phase, and we were told it would be released within 3 weeks to everyone in the United Kingdom. The rationale was that the public would be confused and therefore our app would likely damage the major official effort. Could I ask you, to your knowledge, was any evidence provided to support the claim that public confusion would arise from multiple apps, or was this simply an assertion?
Simply an assertion.
To your knowledge, did the government undertake any risk-benefit assessment comparing the value of your app's real-time symptom data with the potential for public confusion?
I'm not aware of any.
You have detailed that you were told the NHS app would be ready for release within 3 weeks. Do you have any views as to whether that was a realistic timeline, or was it being used as a way to justify delaying your app's progression? Are you able to help at all on that?
At the time, I took it at face value, but clearly in retrospect, it was a fantasy.
And again,
But
just
we had produced one in 5 days, so I knew it was possible. Every time you spoke to them, the timeline changed, so you realised that it was not really a realistic.
Thank you. And then again, just on the same page at page 8, you've also detailed that pressure was put on your university and funding bodies to make you stop promoting the app, although as you've confirmed that you've no written evidence of that. Can I ask you, what impact did that pressure have on you or the app in practice, please?
It made me more determined to carry on.
Now,
It had the opposite effect.
we've heard last week about the development of the app, so we know at this time the NHS did not yet have a functioning alternative app. If you had complied with the request, would you agree that fewer people might have been prompted to report symptoms?
So if we'd stopped the app,
Yes.
well, yes, we wouldn't have any of this data on symptoms. Would have been, and that's not just in the UK, that's in the world. So a lot of the symptomatology of what was going on wouldn't have been available, and it would have been disaster.
Thank you. That can be removed from the screen, please. Now, you had engagement, though, from the Welsh and Scottish government endorsing the app. Could you tell her ladyship about that, please?
Yes, we were contacted by, I think it was either the chief scientific officers or the chief medical officers of both Scotland and Wales to help them with some geolocalization of hotspots initially. So they wanted to see where the problems were in their regions, so they could warn the hospitals and reallocate resources. That was the initial inquiry in both of those places, where they had very little information on the ground about what was going on. So they were initially interested in the spatial idea of what was going on, and thought that it had great potential for them to work out what was happening much faster than any official surveys, which would normally follow 10 to 14 days later in terms of what was happening, or relying on hospital admissions, which again would be 2 to 3 weeks after the initial infections. So we would then be able to predict where hospitals were going to get the biggest burden. So that was their main reason to contact us. And so they eventually did start promoting the app on social media to some extent in both of those places, although not as much as we would have liked.
Thank you. And I think you, in particular for Wales, you identify in your witness statement that you've been able to identify a hotspot in South Wales using the app.
Yes, so there was a couple of hotspots in Wales that we worked with them quite closely to, because they wanted to see how that happened, and worked out the timings of those, and they reported subsequently they found those very useful for their preparation of which hospitals needed to have extra staff in them. So we, in a way, we could predate when the hospitals were going to see a surge in demand by about 2 weeks.
Thank you. Now, you've told us in the witness statement about the engagement with the Scottish Government and the Welsh Government in encouraging the app, but it's right, isn't it, that ultimately then the Welsh Government stopped using the Zoe app. Can you assist us to what you were informed as to why the Welsh Government stopped using the Zoe app? And I think as part of the preparation materials, you've also been provided with what has been said by Joanne Daniels about the reasoning. But from your perspective, what did you understand to be the reason why they stopped using your app in Wales?
At the time, I wasn't following it very closely, so I wasn't really aware that they had changed their view on it at all. I was too occupied in really the rest of it, so I don't have any great insights into that.
Okay, thank you. Now, can we please display your paragraph 18, which is INQ 575990 at page 9. Thank you. So paragraph 18, you detail, we were clearly disappointed that the UK government and NHS England were not interested in taking on our app. We'd only anticipated running it for a couple of weeks and then handing it over, showing how successful it was. We believed it could have been rolled out to the majority of the UK population, as an estimate over 40 million people, helped by the fact that we had the facility of people to use proxy reporting for the young and elderly. This would have given us amazing coverage of the whole of the United Kingdom, and even in the early days, using our subset of population being tested, we got a very accurate representation of the pandemic. We were also able to spot trends before the other systems that eventually came into place, such as the Department of Health ONS surveys and the episodic Oxford Imperial Blood surveys, which were generally a week or two behind the Zoe forecasts and at roughly 100 times the costs. ONS costs 390 million. At Zoe, we decided to continue with the support of the company and its generous investors for another 4 months, although this used up large resources from the small company. But we felt we were doing an amazing service, and we managed to launch in Sweden and the US, although uptake was not as great in those countries for a number of complex local reasons. But can I ask you now, under the heading of what if there had been funding and encouragement for the 40 million potential take-up of the symptom app? Can you give your views about what could have been possible in those early days, please?
Well, it meant we would have had a complete nationwide screening service. We would have been able to work out in real time what was happening with the pandemic rather than relying on a combination of modelling and blood tests, which turned out to be not very accurate. And crucially, the 20-odd billion spent on testing could have been saved or used for other areas of healthcare, because it turns out that if you combined a small amounts of testing with comprehensive symptomatic testing of the whole population, you end up with a pretty comprehensive way of working out what's going on, and it's much more cost effective. So, and it would have reached many other areas of the population that weren't able to get their testing done, as we've been hearing. So, weren't near one of these Lighthouse schemes, or because it would have been able to go into every community. And the idea is we would have gone into some of these smaller communities using these proxies, would have had the money to translate it into other languages, would have been able to get much more we just showed what you could do with very limited resources, but if just 10 times more resources had been put into it, it could have had a multiplicative effect.
Can I just ask, I'm not quite following, how could it have saved the 20 billion plus on testing? Because you would have used, so if I'm a user of your app, find out that loss of smell could be a symptom. And then I thought the idea was I would then go and get tested to know that I was COVID positive. So how would you save the money on the testing programme as a whole?
Well, we'd have had it up. The idea is you set up an algorithm. What we did initially, when only a subset of people were getting tested, we gave you a prediction saying, well, with your symptoms, you're 95% certain to have COVID. Stay at home, don't.
So the effect of the test, you're basically advising me that I'm likely to be positive, so stay at home.
Correct. And now we know that the testing wasn't 100% positive, certain anyway, only about 70%. It would have served that same purpose. In retrospect, it looks like you did a good algorithm based on symptoms was about as accurate as these tests were for the overall population. Again, at a fraction of the cost. And also, you're saving 2 or 3 days. So that's quite crucial in this whole idea of an infectious pandemic, because in that time, you've got 3 days of spread to other people using the system of going, waiting for your test, getting the result back 24 hours later. All this time, you're potentially infecting other people, whereas an instant app that gives you a prediction would allow you to stay at home, isolate much earlier.
Thank you. Now, you've already touched upon with her ladyship the discussion that was you could continue with developing your app on the condition that once the NHS app was launched, that you would then cease what you were doing and support their endeavours. But to your knowledge, was any consideration given by the UK government to the potential benefits of the Zoe and NHSX apps operating in parallel, particularly in capturing data from different segments of the population or from those who may have had lower trust in government platforms?
We did suggest it, but it was never taken up. And no one ever came back and asked us for any feasibility.
Thank you.
To whom did you suggest it?
NHSX several times in calls we had, and as we were getting progress reports of their pilot studies, we were saying, well, we can do this in parallel. So but then it petered out, and they didn't talk to us after the first few months after those initial pilots.
Can I ask you, did the data collected through your app reveal any early patterns of disparity in symptoms, testing access, or outcomes among ethnic minority populations? And if so, how are those insights communicated to public health authorities?
Yes, well, I have referred to this as one of the first studies we did of healthcare workers. So it was clear that we saw in that data, which was based on about 2.5 million population and about 50,000 healthcare workers, that there were big differences between groups, and there were 4- to 5-fold increased risks in ethnic minority healthcare workers compared to non-Hispanic white healthcare workers. And we published these results in press releases and preprints and in journals like The Lancet, so they were very public.
Thank you. And can I also ask, please, to what extent was your app successful in reaching diverse communities, including those from ethnic minority backgrounds, or those typically underrepresented in health data collection?
Not as effective as we would have liked. So we were underrepresented in those groups, and that was seen in our data. So we had a greater proportion of white middle-class population than you would expect in a true survey, but we did have all groups were represented. It just wasn't in the right amounts. So it was generalizable but not representative.
Thank you. Could we please go to your paragraph 20 in your statement 575990, which is at page 10, please. It's just building on what we've touched upon relating to the what-if scenarios, please. Now, if we can go down, please, to paragraph 21, please. Thank you. You state that a big reason our app was not trusted enough was a problem of missing asymptomatic cases. And you continue that it became clear that asymptomatic individuals had lower viral loads and so are less infectious, whereas missing new symptoms like loss of smell and telling them they were uninfected was likely a worse mistake in public health terms, as they had high viral loads and were highly infectious. Could you provide any details, please, of any of the liaison or discussions you had with either representatives of the Welsh Government or Scottish Government or Public Health Wales or Public Health Scotland when they were engaging with your app, please, in respect of the role of asymptomatic transmission or testing, please?
To my knowledge, that wasn't discussed with them. They didn't raise those questions.
Thank you. And are you able to give any explanation why the Welsh Government so proactively initially embraced your app and its potential contribution in a way to the United Kingdom Government's response?
So the question is, why did the Welsh and Scottish respond and not?
Yes, so proactively. And do you see any correlation between take-up by Scotland and Wales as to having any impact or contribution to the UK government's response to your app?
No, I assumed that the NHS England and the UK would do the same as Wales and Scotland, so I was surprised when nothing happened and they didn't reply.
Thank you.
I'm assuming that Northern Ireland didn't respond or engage with you from what you
No,
said.
we didn't have any communication with Northern Ireland, and it turned out that of the separate countries, it was the one that we had the least amount of data on, so we weren't very good at reporting there. And so not having someone who was engaging with us, it was very difficult to promote it there.
Thank you. Now, given that you've already told us about, and in the statement as well, that you were able to identify outbreaks in South Wales ahead of official statistics, do you believe similar early warnings could have been generated United Kingdom-wide had the governments of each of the devolved nations and the United Kingdom government collaborated with you more fully?
Yes, I do.
And are you able to assist as to how many days or weeks of early warning might have been provided in respect of what might have been happening in regions, please?
Well, I had my earlier answer about how our app was giving data before some of these surveys. So it depends on the timeline we're talking about. Once the ONS survey got up and running, that was able to deliver these 2 weekly reports that, depending on when they came in, would say what was happening overall in the country. But we were always ahead by at least a week, 10 days of any other data sources. So I think for planning and hospitals and closing down epicenters, it would have been very useful for the vast majority of the country.
Thank you. Can we please display your paragraph 22, which is INQ 575990 at page 11? Could that be expanded, please? You say this: the impact on health and finances of not using our app nationally is hard to quantify with any precision, but the insistence to continue to rely solely on testing and 2 to 3 symptoms for several months undoubtedly led to hundreds of thousands of excess infections, thousands of extra long COVID-19 cases, and could have saved at least 10 billion if used properly in conjunction with testing. As an example, we estimated with data from 3.2 million people that nearly 16% of cases presented solely with loss of smell, and this symptom was by far the most predictive of COVID-19 infection. It also lasted much longer than fever, so more likely to be noticed. At the time, the government claimed the real figure was less than 2%. So since we first alerted our users with an anosmia to self-isolate on the 1st of April to the 18th of May, when the United Kingdom government finally agreed to add anosmia as a criteria for testing and isolation, over 6 weeks of government delay had occurred. In this time, many extra COVID-19 cases could have been diagnosed early and a large proportion prevented from infecting others by staying home, instead of wasting 22 billion on a test and trace system which never worked properly. An integrated national app with symptom reporting and selected test sampling would have been done for a fraction of the cost. Professor Spector, is there anything you wish to expand upon those clear views expressed in your statement?
No, I don't think so. I didn't do a full financial assessment, so this is my back of an envelope calculation of what it would be, but it just shows the magnitude of both the cases and the potential cost savings could have been reached.
I was thinking about how, if I want to get 10% discount, I have to provide my details. Was your database not an extraordinarily useful source of, not information, but a contactable source for the government in launching their app? So you've got 1, 2, and then 4 million users, and you can put a message out there, go and use the NHS app. Was that not a hugely valuable database source for the government?
Potentially for the government, yes, it would have been.
We can contact 2 to 4 million. They may not all be in the UK, obviously, but we can certainly contact.
Most of them were in the UK, so yes, it would have been an easy way to launch it very fast rather than doing their own pilots.
So you've got the two advantages. One, of course, the really important symptom tracker, but then also, if you believe in the contact tracing app, the ability to contact all those people and tell them to use it.
Who you knew were good users, who had already been sort of indoctrinated into the way of doing it on a daily basis. Absolutely, yes, it would have been.
Professor Spector, can we now look at the initial, when the government did announce the change in symptoms, please, on the 18th of May? It's INQ 237496. So this was the oral statement to Parliament on the 18th of May. Thank you. So just to orientate ourselves, thank you. If we can move forward to page 3, please. Thank you. We can expand, please. Throughout the pandemic, we've said that if you develop a new continuous cough or a fever, then you should immediately self-isolate. From today, we are including anosmia, which means that if you've lost your sense of smell or are experiencing a change in your normal sense of smell or taste, that can be a symptom of coronavirus, even where the other symptoms are not present. Pausing there, have you any views on that messaging, particularly in the context of the 16% probability that you had identified from your studies?
It seems to be slightly trivialising it, just adding it as an add-on, that this is, a small extra thing they're doing. It also doesn't, loss of sense of smell or taste should be more prominent there. So many people might read that and miss that part of it. And it's very hard to separate smell and taste in the population. The two really go hand in hand. And that really should have been highlighted much more than it was.
Thank you.
As well as its importance, and stating that statistic, which was based on several million people's data from across the world. So we would have put it in context much more.
Thank you. And I want to ask for clarification of any views also. The next sentence, please. So from today, if you develop a continuous cough or fever or anosmia, you should immediately self-isolate for at least 7 days in line with the guidelines. And just pausing there, obviously the advice about self-isolation, anosmia is only the loss of smell, is that correct? There's a separate medical term for loss of taste, ageusia.
Ageusia, yeah.
And so from a clarity of messaging linked to symptoms, do you have any views about this?
It falls short of being clear, and they should, I think, probably have used the popular terms for it anyway, rather than trying to medicalise it.
Thank
I
you.
think that, in retrospect, that was a mistake.
Can we then look at the publication of the statement by the United Kingdom Chief Medical Officers, please? It's INQ 237497. Thank you. So just orientate ourselves. And then over the page, please. It may be you've answered these questions already, but we can see this is then the publication supported by each of the Chief Medical Officers of England, Wales, Scotland and Northern Ireland. Again, we see from today all individuals should self-isolate if they develop a new continuous cough or fever or anosmia. Anosmia is the loss of or a change in your normal sense of smell. It can also affect your sense of taste, as the two are closely linked. Is there any view you have around this messaging in the context of what your study had identified about clarity of communication?
It's better than the last one, but it's still not perfect because the two go together. Some people everything just tasted strange. Garlic tasted of asparagus or weird sensations like this. Drinking a beer just tasted very strange, and they didn't notice differences in smell. So I think, it should have just been a loss of a change in your normal sense of smell or taste, and left it at that.
Thank you. Professor Spector, finally for my purposes, can we turn to your recommendations as detailed within your witness statement, please? It's your paragraph 23 at page 11 of your statement, 575990. You detail that you believe the Zoe app has shown that a strategy that includes a national symptom-based app is essential as an early response tool, allowing the government and the population to know what is going on and assess their personal risks. This should be done at the same time as labs are looking for good, rapid diagnostic tests they can subsequently roll out if needed. But future accurate tests cannot be relied on. We used a test with only 70% sensitivity for COVID and must consider this may be not easy or rapid for the next pandemic pathogen. The government should change its mindset and encourage small companies and universities to develop tools rather than trying to shut them down or see them as lesser value. Once developed, they can be badged as official UK health tools. Government and Department of Health responses will always be slower than industry, and this hard lesson needs to be learned. Professor Spector, is there anything you want to say to expand upon that, and particularly what you say about the need for the government to change its mindset?
Yeah, this is an example of government, Department of Health mindsets that they don't like to change their opinions easily, and they're not flexible. They came to a conclusion that these are the symptoms. They had a small group of people making these decisions. They said the public could only take a certain amount of information, otherwise, they'll get confused. Therefore, we mustn't confuse the public, even if the science changes quite considerably. And this is a really bad mistake because it makes the public totally lose trust with a government. And we see this time and again. I'm seeing it in the nutrition field all the time. They won't change some rule, and the same committee, the same group of people is there making those decisions. They never get new people in that don't have a vested interest in keeping those things going. So this is just an example of how many things work, unfortunately, in this country, and how we've ended up with what was the best public health system in the world to perhaps one of the poorest in the developing countries. We're not protected by our public health department anymore, and it's interesting that I never had one communication from Public Health England in all this time, and even now have not had anyone coming to say, what lessons could we learn from your app that you interacted with these millions of people who gave you all their data, and people are still logging today. How did you do it? How can we do this for the future? So I think it's frightening that that hasn't happened, and that we don't have an app ready to go for the next pandemic where we may not know what the virus is. We may not know if it might be a fungus, it might be a nerve agent. We don't know. But if we have this technology ready to go, if a company of 20 engineers put this out in 4 or 5 days, what should a huge country like the United Kingdom be able to do? They should be able to get something out in a matter of hours if it's all set up and teed up to do this. And so that's really my main plea here is let's not repeat mistakes. Let's not assume that symptoms are trivialized. If we trivialized diseases based on symptoms, we would dismiss the whole of mental health as not being diagnosable. We don't do that. We trust in symptom clusters. Let's do this because it's completely doable. So I would like to be protected against the next pandemic by this being rolled out and we learn our lessons.
Thank you. Professor Spector, I do have some additional questions just to see if you have any views, again, to inform recommendations. Can I ask, please, what lessons should be drawn from the Zoe app about the importance of participatory, community-driven data collection in improving equity in pandemic response?
I think it's a perfect example of not forcing people to come for testing, but allowing them to go to their homes, and most people have access to the internet, so it does allow equity. And if the funding is there to translate it into other languages, then it can go broadly. And if we use this proxy system, it would also allow community leaders to go and disseminate it into those poorer parts of society. So I think it fits perfectly into that remit.
Thank you. From your experience or expertise, how can digital health technologies be better designed to build trust with ethnic minority users, reduce digital exclusion, and support culturally appropriate communication strategies?
I've partly answered that, but I think allowing AI to change the language, which can be done very simply now. And I think what we showed in this is that by providing data back to people, that enables this trust, this two-way system. And this is something the government still hasn't learned. So most surveys done by government do not give anything information back, much too worried about data breaches than they are about health of the nation. And I think this is at the heart of a lot of these problems, why governments do not embrace systems like we were able to do at Zoe, is because of this fear aversion of letting someone see data they shouldn't see at the cost of people's lives. And I think this runs very deep in our system. But we showed if you give people back data, they respond and give you their personal data, and it really does work. And it's why it was so popular. And it also provided, we haven't talked about, a psychological help for many people as well. So people still stop me in the street, say, thank you. You got me through the pandemic. With the app, I felt there was someone I could talk to. And I think this is something that may not get mentioned much in this inquiry, but I think the psychological elements of how you can support a population, this is a great way of doing it.
Thank you. And that may feed into this next question, and I've only got 2 questions now, Professor Spector. In light of the lessons from the Zoe app, how can future public health campaigns ensure that messaging about health risks, testing, is culturally appropriate and tailored to diverse ethnic communities, particularly those that were historically hesitant to engage with government-led initiatives?
I think I've probably answered that mainly in the previous answer.
Thank you. And then finally, please, do you have any views as to centralised control over testing and data systems, over opportunities to work with community-informed, independent tools like the Zoe app, and demographic inclusivity or representation?
Yes, well, I think centralising in this scenario, we've seen the difference between what a small startup company could do and what a huge centralised system like NHSX was able to do. One was a success, one was a failure.
Lady, those are my questions. There are Rule 10 requests from FEMHO and COVID Brief Families for Justice UK.
I was just checking. I wasn't sure whether you hadn't asked Mr. Thomas's questions.
Oh. Well, I think I have.
I think you've asked them almost word for word, hasn't she, Mr. Thomas?
More or less. Can I just
Yes, of course.
piggyback on just one?
Yep.
Can I apologise to
No,
my learned friends?
not at all. Good morning,
This is Mr.
Professor.
Thomas.
Leslie Thomas. I'm representing FEMHO, the Federation of Ethnic Minority Healthcare Workers. Ms. Cartwright of King's Counsel has touched upon the questions that I did want to ask you. Can I just ask one question that flows on from that? And just so you're aware of the context, those who I represent are, very concerned and wish to examine the extent to which government preference for centralised control may have restricted the integration of independent community-driven tools such as the Zoe app, and want to know and explore whether there are alternatives for a more inclusive approach going forward and being forward-looking. So that's the context, okay? So I suppose the question is this. Were there actually concerns around demographic inclusivity or representation in relation to the existing government systems, part of your rationale for proposing closer collaboration with the state? Was that the rationale behind it?
I don't think so. I mean, our rationale was that we couldn't fund this ourselves for much longer, that we wanted it to get beyond just a few million people to the vast majority of the country, to all, socioeconomic groups. It wasn't specifically targeting, well, we're not hitting these people. We just wanted it as widely as possible. We appreciated that our survey, could have been better had it included more ethnic minorities and people in lower socioeconomic groups. But it wasn't the main rationale for trying to get the government to expand it. We did have some discussions with the London boroughs, interestingly, at one point. The South 9 boroughs, I think it was, that had a lot of ethnic minority groups in them, to see if we could get the app rolled out to those with translations, etc. We talked about it. They were very keen on it. There was ultimately no funding for it. So, but we were aware of that at that stage. But that was after the government had said, no, we're not interested in working with you.
All right, the final question then is this. Looking forward, because we've been told that there will be another pandemic at some point, what would be your advice to ensure that there is greater inclusivity, in this sphere? What would the advice be that you would give?
I would be doing pilots of these sort of apps in different groups now. I would be working with community leaders to say, okay, if we give you this app, you might have some group of non-English speaking immigrants, and you say, well, okay, how would we go about this? Talking to schools in deprived areas and saying, okay, could the teacher be the one that disseminates this to everybody? In the same way that is happening with some general health apps. That in general, a lot of these groups are missing out on some of this digital health revolution. So I think I'd be just integrating this pandemic prevention into those things and make it part of the standard procedures. But I'm hopeful that, with AI being able to convert language, this shouldn't be much of a problem in the future. It's moving so fast.
Thank you, Professor. Thank you, my lady.
Thank you, Mr. Thomas. Mr. Weaver. Mr. Weaver's just there.
Thank you, my lady. Professor Spector, good morning.
Good morning.
My name is Christian Weaver, and I ask questions on behalf of COVID-bereaved families for Justice UK. In answers to questions from Ms. Cartwright KC, you gave detailed evidence with regards to the issue of taste or smell as key symptoms and your repeated efforts to bring this to the attention of government officials. You explained that your app identified the loss of smell or taste as a key symptom from late March 2020, yet it wasn't recognised as a criterion for testing and isolating until 18th of May, some 6 weeks later. And because of this, you write that some people continued to meet elderly relatives or go to work in health settings because they didn't think they had COVID-19. With that considered, I have just one further question. You note that 16% of individuals with COVID had loss of smell or taste, but no fever and only minor cough. Given that these people were not isolating due to the narrow official case definition, would you agree that this was a blind spot undermining the government's isolation efforts?
Absolutely, yes. And these people were at the highest risk. Nearly all had COVID-19, 3 times more important than any of the other symptoms.
Thank you, Professor Spector. Thank you, my lady.
Thank you, Mr. Weaver. Professor Spector, that completes the questions that we have for you. You described the battles that you had very calmly. I bet you weren't so calm at the time.
No, it was certainly an interesting time, but I should just say I was surrounded by a very supportive team, and everything I've been saying here is not me. It was an amazing group of individuals from the university, from the company, and many other people who came and joined the group we were in. So, I definitely wasn't alone, but certainly an interesting time in my life.
Well, thank you very much for all that you did and your colleagues did and the company did to enable you to develop the app and distribute it.
And the millions of people who, logged their data every day. And I think that's the other message here is that, there is a really willing public out there that really want to help in pandemics, and we've got to learn how to really use them and harness them, because they were amazing, and they gave us all the support and gave me the energy to carry on every day.
Well, we're very lucky that so many people are prepared to help us, particularly people of your skill and ability. So thank you very much indeed for what you did and tried to do, and thank you for your help to the inquiry. Very well, I shall return at midday.
All rise.
Ms. Cartwright.
My lady, please could Professor Malloy be affirmed?
I'd like to repeat after me. I do solemnly, sincerely,
I do solemnly, sincerely,
and truly declare and affirm
that the evidence I shall give
shall be the truth, the whole truth,
the whole truth,
and nothing
but the truth.
Would you like to take a seat?
Thank you.
Could you please tell the inquiry your full name?
Christopher Richard Malloy.
Thank you. Professor Malloy, you provided a witness statement dated the 10th of April 2025. Your signature is on page 85. And can I ask you to confirm are the contents of that statement true to the best of your knowledge and belief?
Yes, they are.
Now, you are here to assist us to give relevant evidence you have to test, trace and isolate, in particular to the initial setting up of the Lighthouse laboratories. But before doing that, can we, first of all, identify your relevant background and expertise before then moving to the relevant background and expertise of your company? Now, it's right, isn't it, that you are Director and Chief Executive Officer of Medicines Discovery Catapult and have been in that role since November 2016.
That's correct.
Thank you. Prior to this, you had a career in industry in international life sciences research and development disciplines.
Yes, that's right.
And you describe yourself as having a 30-year record in industry, including at board and executive level, across a range of life sciences, research and development disciplines, including close involvement with industrialisation of high throughput discovery based on large-scale biological testing.
Yes, that's right.
And I think, can we shorten that? High throughput testing?
Now, high throughput screening is the general term that's used within industry for the testing of many hundreds of thousands or millions of potential new drugs against a biological test.
Thank you. And finally, by way of your background, unless you want to add to anything, you are also an honorary professor at the University of Manchester and chair the Industry Advisory Board at the National Institute for Health and Care Research Biomedical Research Centre.
That's correct, and I'm a trustee at the Institute of Cancer Research.
Thank you. Can you now please assist her ladyship with telling her about Medicines Discovery Catapult and the company itself, but also the principle of Medicines Catapult Discovery, please?
Thank you very much. Good afternoon, my lady. The Medicines Discovery Catapult is the nation's innovation centre for medicines R&D. It is there to industrialise and drive the adoption of new tools and techniques for our sector, driving their adoption through commercial services. It is there to work with young companies, making them fit to fund, working through their R&D plans, working through their risks and their opportunities to help them make good investment decisions and be investable. And that's led to an investment of around about £1.3 billion of private money into companies who we've worked with. And thirdly, and most relevant here for us today, is the work that we do in our international and national R&D programs, a portfolio of between 5 and 7 of these programs. And these include, for example, the rollout of total body imaging with the NHS. It includes the international platform for new medicines for antimicrobial resistance. It includes the launch of the National Dementia Goals Programme, and so on. These are purposeful collaborations anchored through to the patients, often via their medical research charity. And their purpose is to do the things that are hard, to do the things that require combinations of skills, expertise, resources, and that is very typical of what the Catapult has always done since I helped found it at the back end of 2016 into 17. And a very logical starting point for our discussion about the Lighthouse laboratories today.
Thank you. Perhaps if we locate where the company operated from in 2020, it's right, isn't it, that Alderley Park that we've heard about, based in Macclesfield, was where the company was based?
That's correct. Alderley Park is the former European R&D centre for AstraZeneca. AstraZeneca have now relocated their R&D facilities to Cambridge. And the Medicines Discovery Catapult was one of the cornerstone clients at the privatised science park at Alderley Park, run by Bruntwood SciTech.
Thank you. And we'll perhaps touch upon Bruntwood when we hear the steps you took at speed in March of 2020. Now, the phrase, the Lighthouse laboratories, in fact, we have you to thank for that. Is that correct?
It is.
And perhaps if we identify the principle and why you arrived at Lighthouse, you say this in your statement, I christened the Lighthouse Labs as such because of the totemic image of a lighthouse in dark and uncertain times, and because light is generated and measured during the conduct of a PCR test.
Yes, that's true. And the Lighthouse was a unique construct designed to bring together NHS, academia, and industrial skill in a non-profit manner to serve the nation at a time of crisis. That was its purpose. That was the distinct purpose that held it together, the people together, and the project together, and brought thousands and thousands of people together as volunteers and then as short-term workers to deliver that programme of 150 million PCR tests over 2 years. So it was a unique construct, but one designed with purpose and for hope.
Thank you. And in answering that question, you've identified not-for-profit, and we'll come perhaps briefly to look together at what you did and what the company did. But it's right, isn't it, for the commencement of the offer of Alderley Park as a Lighthouse laboratory, it was simply being run not-for-profit?
That's correct. So the Medicines Discovery Catapults, the not-for-profit group, we have commercial services as part of our offering, as defined by our grant from Innovate UK. But all of the initial Lighthouse group in Milton Keynes, at the UK Biocentre, at ourselves at the Medicines Discovery Catapult, the University of Glasgow, and even AstraZeneca, running under a non-profit model, took that as our first principle, that we were here at a time of crisis to lean in, to do what we could, to bring our skills to bear, and to make sure that the nation was served. That was one of its founding principles.
Thank you. I'm going to take you now to you leaning in. And I suspect when you sent this email, you had nothing of Lighthouse in your mind, but let's look at you leaning in, please. Can I have display, please? INQ 510837 and page 1. Thank you. And it's the bottom email, please. This is, I think, essentially you leaning in for the first time on the 19th of March of 2020 at 9:12 in the morning. Dear friends, you are busy. I'll keep it short. You, like us, will be the recipient of hundreds of potential medicines discovery ideas and programmes. We have industry-class skills in coordinating, triaging, diligencing and managing concept to early clinical consortia. We can be of national use, and my team are fully functional. We can scale with our national consulting networks and put money to work well. Please let me know how I can deploy to help you manage the flow and fill the national pipeline. Call me anytime, plug me in or pull me into the right rooms as needed. We are ready and able. Bandwidth is unknown, but let's find out. And that was sent to Louise Wood at Department of Health and Social Care and Fiona Watt, MRC. Can you just identify who that individual is, please?
Fiona Watt was the then Executive Chair of the Medical Research Council.
Thank you. And obviously also Professor John Bell.
Yes.
And in terms of those being the contacts to send the very clear call to step up, why was it you focused your offer to these three individuals, please?
So Louise Wood was at the time running the National Institute for Healthcare Research as part of the Department of Health and Social Care, Fiona running the Medical Research Council, and Professor Sir John Bell, a recognised UK life sciences champion with great experience across the NHS, academia, biotech and large pharma. These individuals were part of my network and well known to me and I to them. So I thought it was a logical place to start. And my approach was around medicines discovery, unsurprisingly, as that was what we understood at the time was going to be a national need, a triage of new potential medicines ideas. The answer I got back was leaning on my prior experience elsewhere.
Thank you. And perhaps if we then look at the top of the page where we can see again you reaching out, thank you, the same day at 4:39 in the afternoon to Jeremy Farrar, again sharing that message. And it's clear from this email that you'd not met Sir Jeremy, and you say this: as we've not met, I did not presume to send it to you, but I'm putting myself and the MDC at your service. Please let me know how we can help manage the multiple streams of translational R&D activity and industrialisation of academic assets that are now flowing. Wellcome supports us to manage and drive these types of R&D consortia, but please also feel free to reference check me with Mike Ferguson and JB if you need to. And can you just identify Mike Ferguson, please?
Professor Sir Mike Ferguson of the University of Dundee.
Thank you. And why in particular were you flagging Professor Ferguson?
He had been and may have been at that time a member of the Wellcome Board.
Thank you. Now, can you perhaps in your words deal with the response that came back and what you did to respond in March?
So I received a phone call back from Sir John Bell, who wished to talk to me about the decision that had been taken to provide high throughput testing of PCR across the nation. And could I, with my prior experience and understanding and industry links and group at the MDC, provide a site at which this may take place? It was clear from that conversation that the site at Milton Keynes, which was the UK Biocentre, which had been co-funded by the Medical Research Council and NIHR, had already been alerted and was mobilising to this end. And could I mobilise a centre in the north or the northwest specifically? That was the first conversation that occurred on that afternoon. I was unaware of what Sir Jeremy had either sent or planned to send to universities at the time, and I had been unaware that that decision had been taken. But it leaned on my skills and experience and publications in the area of high throughput screening, and the fact that many of my senior staff in the Medicines Discovery Catapult came from the high throughput screening group at AstraZeneca that was still also present at Alderley Park at the time.
Thank you. Now, can you assist then as to just a timeline so Her Ladyship understands? It's very difficult to tell the story through such a detailed statement, so I think it's better that you tell it. Really, what I would like to capture, please, from the request then to set up a laboratory, high throughput testing in the Northwest, but then how you ended up essentially being the overseer of the 3 Lighthouse laboratories that were set up in the April of 2020, please.
Thank you. And you'll understand that there was an instant flurry of activity that came after that initial phone call. When I had put the MDC at the service of the nation, I was introduced through to colleagues in the Office for Life Sciences who were staffing and running the so-called Pillar 2, which was the non-NHS, i.e. the NHS augmentation side of the PCR testing program. And in conversations over the following days, I was asked by the Office for Life Sciences, by Kristen MacLeod and others, if I would coordinate the national programme, leveraging my expertise and industry standing. So over those first few days, some clear decisions were taken around how best to perform high throughput screening alongside NHS resources, but using NHS understanding, skills, input, advice, and techniques to deliver. So the Lighthouse Labs were formed on that principle that we were engaged with the NHS from the very early days, within 36 hours of that initial phone call, at the very highest levels of NHS and the Royal College of Pathologists and clinical experts. Because our purpose here was to provide high throughput testing, doing one test at unprecedented pace and scale, to be able to take the pressure off our NHS laboratories, who were already harnessed into Pillar 1, but also we recognised had to provide a wide array of additional testing for inpatients and others that we did not have to. We could apply our industry class experience and skills in automation, in scaling, in quality, and so on, in the service of the nation, doing one thing incredibly well. And that was that's the task we set ourselves to on an industrial scale. And that needed a mobilization of industry experience. And so creating the management teams, those very early management teams at Alderley Park, in Milton Keynes, and ultimately in Scotland, in Glasgow, pulling from the industry community, those people who had that experience, but blending them, binding them to NHS experts, clinical virologists, clinical microbiologists, public health experts, so that we could not only align with what the NHS was doing, but effectively augment it. That was a subject of intense conversation in those very, very early days. And so very grateful to the inquiry for the ability to set that record very straight this morning.
Thank you. Can we please display the map of the Lighthouse laboratories? It's INQ 587456. Sorry. Thank you. Now, if we can just put the outer limit on over when you were involved in overseeing the first four Lighthouse laboratories, which you've already identified, were opened by, obviously, Medicine's Catapult Discovery at Alderley Park in Cheshire. You've already identified that at Milton Keynes, that was UK Biocentre that operated that site.
Yes.
In terms of Cambridge was operated, that was correct, through the University of Cambridge.
And AstraZeneca.
And Glasgow, was that the University of Glasgow?
University of Glasgow.
And was any other private initiative supporting Glasgow?
No.
Thank you. And you've also referenced already the input of virologists. Did each of the Lighthouse laboratories in April 2020 have a clinical lead?
Yes, they did. So the clinical leads who were suggested to us by NHS leaders were brought on each site to advise on its build, to advise on quality, to advise on technique, and there was a group therefore of clinical experts chaired by Dr. Mallow Sudhanva, who was the clinical lead for Milton Keynes, across Professor Paul Clapper in Alderley Park, Professor Rory Gunson in Glasgow, and then Nick Brown at Cambridge.
Thank you. Would you like to give Her Ladyship some impression in terms of the skills and expertise of those four clinical leads at each centre, perhaps starting with Professor Sudhanva?
So across this set of clinical leads were folks who had and do run clinical labs within the NHS, who set the National Health Service exams for virology, members of the Royal College of Pathologists, expert microbiologists with decades of experience of clinical labs, of training, of quality, and of how the NHS does their job in this space. We relied on them every day, and many times every day. They were so deeply involved in this activity, all the way from analysing of borderline results through to process improvements in the laboratories, and so on. We also had early bind-in from former NHS operational managers, Dr. Ian Fry being one, who came to visit our centres and gave us invaluable advice on how they saw the setup of these labs. So the binding of NHS into this programme was immediate, and it was deep, and it was sustained.
Thank you. Now, whilst this is still displayed, it's right, isn't it, that you had the oversight role for the first four Lighthouse laboratories until the July of 2020?
That's correct.
When Professor Dame Dominicek.
Anna Dominicek, yes.
Thank you very much. And can we then just clarify, because we can see that during that period up till July, once the four laboratories were set up, what followed thereafter was under Professor Dominicek's coverage, is that correct? That's
right. And Professor Dominicek was, in fact, the sponsor of the University of Glasgow Lighthouse, so had excellent experience of both the build of that and the running of that from the start. So she took over from me in back end of July, early August.
Thank you. Now, we've already identified that the Glasgow Lighthouse Laboratory and the Cambridge Lighthouse Laboratory had an input from the university sector.
Yes.
And are you able to assist when you were asked to help set up Alderley Park but then oversee the other three? To what extent you were party to discussions about offers that have been made from other academic institutions and universities or other bodies that were offering the ability to do testing, admittedly not through a Lighthouse type scenario, but can you help inform what thought process was given to other offers as those that could say they could run a quantity of PCR tests?
Yeah, I was aware that those offers were coming into Pillar 2. It was neither my role nor my privilege to make those decisions. The discussion on the location of the Scottish Lighthouse was one that I'd been having with Scottish Government. And that was their decision as to where that was eventually sited. Obviously, I was aware from very early, from day one or day two, that the university sector had been asked if it would lend some of its relevant instrumentation to this centralised approach. And that was really the extent of my involvement in what universities were doing where. The University of Cambridge AstraZeneca combination was something that those two parties had come to agreement on separately.
Thank you. And the inquiry last week, in fact, saw emails that were sent by Sir Jeremy Farrar on the 19th of March to the academic institutions, universities with medical schools, essentially doing what you've just said, asking them to essentially surrender their PCR machines to the national Lighthouse effort. Were you aware of that?
Yes, I was. And that was, and I think it's correct, is to universities primarily. And that message also did go out to some private sector providers and biotechs and so on, which led to the identification of about 400 pieces of equipment that were then moved in a logistics exercise to our facilities and enabled us to get going extremely quickly. I don't believe that there was any call ever made to any NHS facilities.
Sorry, my question may have been misleading. I meant universities, like medical schools, that had connections to NHS. So my question may have been misleading. This
was, primarily academic institutions, yes.
Thank you. And then can I ask you, because we know that you did not have a bespoke high throughput for PCRs available at Alderley Park, and I'm going to ask you to detail practically what you did. Was there any thought about, by moving PCR equipment from universities that could be running PCRs, that there needed to be careful consideration about when these machines were moved so that it could be being used most efficiently whilst the Lighthouse labs were being set up?
Yes, and obviously all those machines had to be decontaminated, moved, relocated, and then brought back into operational use. And we tried to do that as sensitively as we could to make sure the instruments went to sites where they could be used as quickly as possible. And engineers from Thermo Fisher and elsewhere were deployed appropriately to make sure they could bring those instruments back into operational use. So that helped us build capacity in a managed way. And it was vital for us to understand what instrumentation was available so that we could do this and we could load balance. One of the things that may be important for the inquiry to hear is that from the start, we wanted to have sites in different parts of the country and recognise that those sites would need to have failover and load balancing across them, because we didn't know in March and April of 2020 if we centralised everything in one place, if that site went down, let us say, in the horrible experience that a large-scale infection ran through it, then we would be in a national risk. So there was diversification of place, and also to reflect the understanding we had about the need for logistics and the requirement to move things to these laboratories from different parts of the country, from Southampton to the Scilly Islands. So that there was a requirement to have a small number of centres, and across those centres, those pieces of instrumentation were moved in as straightforward a way as we could and brought up into operational use. That process takes days or weeks in some cases, so it needed to be handled. It couldn't just be moved overnight and made operational the following day.
Thank you. Can I ask you slightly to slow down? I think between the two of us, we're probably causing the stenographer some concern with keeping up.
My apologies.
No. Now, just to help us understand where the strategy was up to then in the March of 2020, we know the 4 Lighthouse laboratories were set up in the April of 2020. You've talked about the need or desire to set up other laboratories in regional centres. But did you have any role or input when you were in the coordinating role that you handed over in the July of 2020 for the discussions or thought process around the other Lighthouse laboratories that we can see came on them much later in 2020?
I was aware that discussions were ongoing from about June of 2020 by the Pillar 2 leadership and Test and Trace leadership to extend the franchise of the Lighthouse system to other laboratories in different locales and potentially to NHS operated large-scale laboratories. So I was aware that that was going on. I was not actively involved in that discussion, but I did represent to Pillar 2 management some of the options that could be taken if you looked long-term. Once the emergency period had its first run, then it was about the expansion, the long-term expansion of that network. And there were a number of ways in which we could do that. Additional sites was certainly one of those ways, and we took some other approaches as well, which also increased capacity.
Thank you. And so, can you assist then? Who was driving the wider project? Because it seems like whilst you had some peripheral knowledge, your focus was up until July of 2020 on the first four to coordinate.
Absolutely. It was on delivery.
Yes. So who was then driving the wider scoping of additional Lighthouse laboratories?
To my knowledge, there was a group, an NHS group, and I think run by Ian Fry, who was doing that, but as very much as an open part of what Pillar 1 and Pillar 2 were doing. So I was aware that this was going on, that other sites, other locations were being reviewed as potential expansion sites. I was aware that other suppliers, such as Perkin-Elmer, were being talked to about bringing on their own sites using their own technologies. So very aware that while we'd started with this core of these labs, that the modus operandi of those laboratories could be extended through to others to provide additional capacity as we discovered and modelled what the nation would need over the next 18 months.
Thank you. Now, you've helpfully set out the details of what your role envisaged from the March of 2020 to July of 2020. Please could I ask for paragraph 5 of your statement 587344 at page 4 to be displayed. Thank you. At the bottom of the page. Yes, so you tell us that between March 2020 and July 2020, your role was to provide executive coordination services in relation to the setting up of the network and to be responsible to the Department of Health and Social Care for it. Define and maintain a purposeful, consistent and deliverable plan for the network. Coordinate and drive network decision-making and problem-solving. Coordinate the network's activities across what was then 3 to 4 sites across England and Scotland, and in parallel to the laboratory provided separately in Northern Ireland by Randox. So
yes.
Pausing there, can you just assist as to how the 4 Lighthouse laboratories that were set up were different, or if they weren't, and how they fitted with the Randox laboratory at Northern Ireland? And is it correct that Randox traditionally provide clinical PCR tests into the sort of healthcare service?
So in answer to your last point, yes, that's my understanding. They also produce a wide range of diagnostic tests and technologies. So the Lighthouse system was run in parallel to the Randox approach, which was using their own technology and had preceded my involvement with this approach, although I was in touch with the Randox team on a regular basis. and they did receive some capital equipment as part of that message that we discussed a few minutes ago. We did not share reagents because the tests were somewhat different. So the lighthouses were a non-profit approach using initially of those first 4, 3 used the Thermo Fisher approach, and AstraZeneca used one other approach which they had validated back to back with the Thermo Fisher one.
Thank you. And then perhaps if we continue through your role, you've already identified that you were responsible to Pillar 2 for the output of the Lighthouse Labs and to the Lighthouse Labs for access to Pillar 2 resources, and to liaise with essential stakeholders, including NHS, Health and Safety Executive, various industry players, the DHSC and external supply chain providers. And can I ask you, can we have clarity about who those industry players were, please?
So we were working with organisations like Thermo Fisher, for example. We were working with a wide range of suppliers of reagents, of plasticware, of instrumentation. I was in discussion with the likes of, obviously, AstraZeneca, with GSK as well. There were numerous biotech providers and others who I was in conversation with on a daily basis, either with offers of help, assistance, staffing, advice. It was a wide array. We could spend a long time going through the entire list, but it was a cornucopia of industry players who provided their skills, their understanding, and their advice.
Thank you. Now, can you assist then as to how you practically and financially were able to repurpose Alderley Park to then become a high throughput PCR Lighthouse laboratory? So
we investigated a number of different sites in the local area, including the University of Manchester, and my grateful thanks to Professors Graham Lord and Nancy Rothwell for their help in that. We identified, however, that Alderley Park, where we are resident, had an available standalone building that we could isolate from the rest of the site. It had Class 3 waste disposal capability and incineration, which we knew was going to be a really important part of the build of this facility. And therefore, we felt that site would offer us the best opportunity to construct on a sort of cellular level the facility that we needed. And I contacted Bruntwood Scitech, the owners of the Alderley Park facility, who immediately made space available and immediately, without needs for money to change hands, to lean in and start converting that facility for our use.
And so in terms of what you were doing in the setup at Alderley Park, was it underpinned by a contract, or were you acting in good faith?
Good faith at the time.
And can you give us some idea as to how much the company essentially had to lend or sub the Department of Health and Social Care to set up Alderley Park?
So at the time, by the time we had our first contract with the Department of Health, which was in late April, the Catapult had already spent over £1.5 million on supporting this programme. And all of the Lighthouse facilities at that time, and by the time that the cash finally started to flow, had invested millions in supporting this programme. It's a really important thing that I would like the inquiry to understand, is quite how much all of these organisations leaned in the national interest, not in their own interest, but in the interest of their fellow citizens, and making a programme work effectively at speed and without the barriers of having to contract. And that's a vital thing that I hope comes through very clearly today.
Thank you. Now, I think when the first contract was entered into on a not-for-profit basis,
correct,
it's right, isn't it, that it was important that there was an indemnity provided to you as part of that contract, which enabled you to operate not-for-profit?
It enabled us to operate. and it enabled us at a time of great uncertainty to put into effect the programme that we had created. And I use the term we across the Lighthouse network, which is a collective. This was not one company owned by one individual. It was not a private sector. It was not a commercial deal. This was a collection of non-profit organisations leaning in, paying out, and making sure that the nation was served. It was important to make sure that the department, which they did, understood that and the risks that we were taking in doing so, and helpfully helped us manage those risks.
Thank you. And I know there came a time, as you tell us in the statement, where essentially you moved to the second contract for the services of medicine
Yes.
catapult discovery.
Mm-hmm.
And can you just explain to her ladyship how that contract then changed and what one of the issues was that resulted in a different approach needing to be adopted?
Yeah. So we were asked by the Department of Social Care, of Health and Social Care, in the autumn of 2020 to move our services from a non-profit into a commercial standing. And that was for reasons that the Department of Health wished to reduce and or remove the indemnity, and recognised at the time that would need to be balanced with a commercial contract. So that was an approach by the department to the Lighthouse network. It's an obligation for the Medicines Discovery Catapult under our grant funding agreement if we are working in a commercial sense, and we do as part of our business, to make sure that we do those at market terms and do not undercut the market. So we were then obliged to move from our non-profit pass-through approach into a commercial contract where we took commercial risk and we were paid a market rate.
Thank you. And I think having handed over the coordination to Professor Dominicek, certainly from August 2020, you were then acting as the Chief Executive Officer of the company.
That's right.
And maintained the overall responsibility and accountability for the Alderley Park Lighthouse Lab.
Correct.
Okay, thank you. Then, with that having been identified in the 5 minutes or so we've got before we break for lunch, the inquiry is much evidence in respect of the lean in from the private sector and various companies that assisted with different aspects of the test, trace, isolate, contact tracing. But in particular, the inquiry is going to hear some evidence this afternoon from Deloitte. Can you assist in terms of the contribution when you were overseeing these first 4 Lighthouse laboratories that Deloitte were providing in the setup, please?
From the start, and I've already mentioned that the Milton Keynes mobilisation happened, a few days in advance of my involvement, and the Deloitte group were helping them on, build out their warehouse, build out their systems. And also working with the Department of Health and Social Care in a sort of central framework and providing a range of different resources through to that UK Biocentre laboratory. Those resources were taken up by Alderley Park and by Glasgow to different levels, as was needed to fill resource gaps. We also had significant input and resources from our armed services who built out warehouses and so on with their logistical understanding. And the Deloitte group acted as a central resource, providing logistics understanding, demand forecasting, monitoring, reporting, certain discrete pieces of software development where we bridged data from the lighthouses through into NHS systems, so performed a wide range of functions. But that was the primary, my primary understanding of the interaction.
Thank you. And you've mentioned there, I think a small project. I think that was the phrase. If I'm paraphrasing it.
Okay.
But can we just perhaps crystallise issue of data and the access to data that Lighthouse laboratories have? Is it correct that when the samples then started to flow through, that there would be the barcode on the sample that was the PCR test, essentially, the PCR sample?
Yeah.
And so can you help us as to what data that you, as the operators of the Lighthouse laboratories, had access to, and what you needed to have access to, please?
Okay, thank you. And I presage that by saying that I've spent about 20 years in and around the healthcare data environment. I understand both the opportunities that it has, but also the concerns that it raises, and the information governance that's absolutely required around personal information and health data. So in the interests of making sure that the lighthouses were faster to set up and cleaner in their both input and output, and in discussion with NHS colleagues, we chose the following: that the Lighthouse labs would never receive personal health data, even a name. What they would receive is a barcode. That barcode, which many of you may be familiar with from your own experience of testing, was related to information, your personal information that only the NHS held. We would receive that barcode on that tube and report back through existing NHS systems into the NHS network a result against that barcode, positive, negative, or void. What that meant is that we could move quickly. We had reduced amounts of information governance that we had to implement, and therefore that we could speed up the delivery of the Lighthouse labs to the nation. And it was a simpler, easier to implement approach.
Thank you. And so you've identified, essentially, having run the process of the test, 3 results, positive, negative, or void. Is it correct then that that would be communicated essentially to the relevant healthcare to notify the patient via a system called NPEX?
Yes, NPEX was the extant system used by the NHS to import data from non-NHS laboratories. And our colleagues at Deloitte wrote a simple piece of bridging software which allowed our own laboratory information management system to port data in through NPEX into the NHS systems, at which point that was absolutely under the control and direction of NHS to use for whatever means possible. First and foremost, of course, getting the information back to citizens.
Thank you. And as a system that had existed pre-pandemic, is it correct that NPEX was already there as a system for
Yes,
a way of third
that was my
parties
understanding.
to get patient data across to NHS systems?
That was my understanding and the rationale for its use.
Thank you. And you described, though, that what Deloitte did was create that simple bridging to allow the results from the Lighthouse labs to be then sent where they needed to be for that result to be processed.
Exactly. And we chose one laboratory information management system to run across all of the Lighthouse labs to make that bridge as simple and as robust as it could be.
And is there an identifiable name for that laboratory management system that we need to know, or is it just the management
It was a system then developed and sold by a company called Brooks Life Sciences.
Thank you. Ladies, is that a convenient moment?
Certainly. I hope you were warned, Professor Malloy.
I was.
That we'd be taking a break. I'm afraid I've got a meeting, so I have to rush. I shall return at 1:45.
Thank you, my lady.